Well, for me it's seemingly late in the day, and unfortunately you're going to have to wear earphones, many of you, because my ability to speak Portuguese is less than zero. If you're wearing earphones, however, and you are plugged into your iPad, I won't know the difference if you're listening to pop music. Well, I have a fairly long period of time, especially in view of the fact that I'm having to present a PowerPoint presentation, and everybody's PowerPoint poisoned at the moment. So I'm not able to use my computer and do real-time demonstrations as I would have preferred to do. Having said that, I think that we will manage to have an interesting discussion. I'm sort of going back in time almost, in that I'm actually going to talk very little about cone beam CT or about any of the new imaging devices. I'm actually going back almost or more than 60 years and talking about panoramic radiology, which took a very long time to become a popular modality in dentistry. And we'll have a look at some of the history of how panoramas were developed and to what extent we can improve the image quality that's possible within the scope of panoramic radiography. And then just briefly at the end, I will talk about cone beam CT. So thank you for the invitation to CONABRO. And my talk will be the latest generation panoramic radiology, advantages of cadmium telluride sensors for optimizing image quality. So it's a very narrow field to cover in an hour and a half's lecture. However, I'm not only going to be talking about cadmium telluride. Of course, we will talk about high technology, and while we're talking about high technology, it would be probably appreciated by the people sitting next to you if you would turn off your cell phones. So, Dabi Atlante, I must admit, I really had not heard of many Brazilian companies, although I had received some years ago a Brazilian soccer or football shirt. And I believe that there is a game, or was a game of football earlier today, in which one of the local teams was ahead when I last was watching TV. Dabi Atlante, I met for the first time, I believe, in 2003, when Edmir Costa was running the International Association of Dentomaxillofacial Radiology meeting in Florianopolis. And they were very kind in sending me the soccer shirt, which I wear for my cycling classes at lunchtime as often as my wife will allow me to wear it. So I did know about Dabi Atlante from 2003, but I have not worked with Dabi Atlante at all. However, since 2007, I have had cadmium telluride sensors that were developed by the IAT Corporation in Finland and are the technology that is being used by Dabi Atlante in Brazil and elsewhere. There is a combination here, Brazil, Finland, but Finland is not the source of the cadmium telluride ingots. In fact, there's a Japanese connection. The factory where the ingots are made is Akrarad, and that's in Okinawa, in the southern island of Japan. So this is an international development of a technology. This is where my dental school was when I was at dental school last week. And this is where we are now, just a short time later. We have lots of beautiful toys to play with, and for the most part, I'm just going to be talking about one of them, and one that was developed really in the 1950s, but only became popular in Japan and the United States in the 1990s, and is really taking off well in Brazil at the moment. So, going digital, panoramic radiology selecting the way forward. I've got an hour and a half, so I'm sure that my time will melt. And what I say, I'm sure, will be somewhat controversial, and I'm more than willing to put my head in the mouth of the lion and be decapitated if necessary. So, how did dental radiography start? We have to go back to 1895 and the discovery of the X-ray. The first dental radiographs took a 25-minute exposure using silver halide film applied to glass plates. Not exactly the greenest of technologies. Silver halide, something that many of you in Brazil still use in your dental offices. The waste, the silver waste in the fixer is certainly not good for the environment. So as we move forwards, obviously, moving to digital is a tremendous way forwards. We'll talk about this a little bit later, but of course, there are substances in digital sensors that are not good to the environment, but fortunately, we don't dispose of them every day. We actually take substances from the environment and put them into digital sensors, and they stay there for many, many years because they don't break down. In the case of most digital sensors, we're talking about maybe something poisonous like cesium iodide. But we don't put it in patients' mouths and we don't throw it away. Cadmium telluride is very similar. We're taking it out of the environment and putting it into a permanent usage, unlike maybe cadmium cells or batteries that are disposed of fairly frequently. Certainly moving to digital, we're moving towards a greener world when we have no disposables. The first radiographs took 25 minutes, and they looked like bite wings, and they were made in Germany by Otto Wolkoff. C. Edmund Kells in the United States was a little bit concerned about infection control, so he covered his assistants, which are very unusual to have female assistants back in 1896. He made them wear protective clothing. This wasn't because radiation was making their hair fall out. And in fact, the original films were as thick as sensors are nowadays because they had Belgium glass inside of them. And in 1898, one had something that looked like a digital sensor of today. Looks very much like the DEXIS sensor sold by one of the Danaher group of companies. So initially, we weren't too worried about radiation safety, about the amount of radiation that was being used. In fact, there wasn't a housing around the original X-ray tubes. They were air-cooled, and there were wires to protect the patient from touching the tube because they could burn their hands. And there was a piece of fishing wire, or it looks like fishing line, that was holding this in place. And in fact, we talk about product liability nowadays. In fact, if you go to the dental items of interest in the 1910s and 1920s, you'll find that there were a number of malpractice suits against X-ray manufacturers from spouses of dentists who got electrocuted with these systems. And in fact, originally, most people didn't use film. They actually used fluoroscopes. They used a fluorescent screen. Thomas Edison, in fact, patented that. And so George Eastman, of what used to be a big company, I don't know what's happened to it now, it used to be called Kodak, and sold off part to become Carestream. That particular individual sent somebody from my present hometown, Louisville, Kentucky, to look into developing good film for usage, because you couldn't fit a fluoroscope in a patient's mouth at that time. So let's have a look towards panorama. An intraoral film is not a panorama. We have to have a greater view to get a total picture of the jaws. And the first way was to put a film in the mouth. And again, we have to go to Japan for this idea. Dr. Numata in the 1930s decided that you could place a film in the patient's mouth. And Japanese mouths are not that large usually, so I'm not quite sure how they managed to get this film in. And then you could scan, using a scanographic method, around the outside of the patient's head to produce a silver halide film. It didn't really catch on. I wonder why. The next idea was to actually put a source of radiation in the patient's mouth and to have the film wrapped around the outside of the head. And this actually was patented as early as the 1930s and commercialized in the 1980s by Siemens and then Sirona as the Status X. There was a lot of distortion because the source to object distance and object to receptor distance were not ideal. I don't know whether the batteries are dying in this or not. The next was to actually have a source and the film outside the patient's mouth. And here we can see such a situation in which we have the film, still film, outside of the patient's head and the source of radiation. And we're still using, in a sense, the idea of Numata of having bits created with this image bit by bit. But in addition, there is pantomography theory, so we're getting a tomograph as well as having a scanographic image. Maybe I need some new batteries. Here we can see the equivalent of creating a film around the patient's head to produce a total view of the patient. So the image is created bit by bit as the exposure happens past a secondary slit, and this time with light-sensitive film that has been exposed indirectly using a scintillator, using basically what was then known as intensifying screens. So this is an example of another one of these systems, but now in this particular case, instead of having a secondary slit, a virtual image is being produced by having an array that can absorb the X-rays and create an image digitally. When it comes to panoramic radiographs that are produced with an external source and an external detector, we can talk about the line pair resolution of the image. Only in the zone of highest resolution do we get the maximum resolution, and that tends to be lingual to the central area of what is known as the image layer or the focal trough. At any point beyond that, in either side, we'll get a reduction in the resolution, spatial resolution of the image, and the acceptable range of unsharpness is about 1.5 line pairs per millimeter. Panoramic radiographs have a lot of information on them, and in fact, I at one time put out a pamphlet for Panoramic Corporation that had a total of 50 different landmarks that were registered. That was because another company had 18 and we wanted to have more. There's actually an infinite number of different anatomical landmarks almost if one picks them out individually. Each tooth, each segment of each tooth, the enamel, the dentin, the pulp, the periapical areas. Panoramic radiographs have a tremendous amount of information in them and perhaps are one of the most difficult images to read well. You need to spend time and learn about the images. However, most dentists have spent time in dental school, at least 4 years, learning about panoramic anatomy and know it very well in comparison with three-dimensional anatomy, which they're only just beginning to learn. So here's an example of a poor quality analog image that I hesitate to say where it was made, so I won't. Typical of most medical hospitals when film was used. When we retake the image, we can see that there was a need to retake the image, that we can't finish having bad quality. New technologies, as we move forwards, we can move to a choice of solid state technology in both 2 or 3 dimensions. And this is the quality of the image that we can get with panoramics. At one time, it was always necessary really to have the resolution of a full mouth series to get a complete, comprehensive panoramic view of the mouth in high enough resolution. The improvements that have occurred with panoramic radiology are such that we can now pretty much do away with the full mouth series and just use individual periapicals and bite wings, and where deemed necessary, a panoramic radiograph instead of a full mouth series. In many parts of the world, it's now considered to be malpractice, pretty much, to take the traditional full mouth series. It's an excessive radiation use for the patient. Not only are the images much better than the original images that were made with panoramics, but they're generally of lower dose. The reason that they are of much better quality is, first of all, that the computer is controlling the movement or the motion. It's not a mechanical motion anymore. Secondly, that one can customize to some extent for the individual patient. And one of the advantages of cadmium telluride over the other techniques that are available is that one can get a 400 megabyte image and select within a 3 centimeter area the customized focal trough for the individual patient. So digital panoramic radiology, is that something new? In fact, it isn't. In the late 1970s, early 1980s, Richard Albert and James Campbell had the idea of digital panoramics and actually went forward to create images that were pretty darn decent at a time when the chairs were still moving to produce images. The SS White was originally interested in the concept for panoramic radiology, but closed its dental radiology business before the project was realized. Instead, they produced an image that you wouldn't want to have your patient's head inside of. This is the device that was created called a DigiRay, and the digiray was successful for industrial testing of space shuttle O-rings for NASA and other industrial testing. So what started with dentistry moved into industry. First successful digital imaging in dentistry was that was developed by Francis Moyen. When he was a student at the University of Toulouse in France, he had the endodontic clinic at the top of the 5th flight of stairs. And of course, all of the film processors were in the basement, 6 floors below. The patients were left there with the endodontic wires in their mouth, and during the time that he was running up and down the stairs, hoping that the patients wouldn't bite down on the endodontic points, he had the idea of, I can take a panoramic radiograph. That produces light. I can put a camera behind the light, and I can capture an image, like a video image. And by the way, unlike Thomas Edison, I can make that fluoroscope small enough to put in a patient's mouth. And so the first patent for intraoral digital radiology was issued in Europe in 1983 and became a product in 1987 in Europe and in 1990 in the United States. This is, in fact, the first radiovisiograph taken by Francis in his living room. And this was an extracted tooth, Céline Moyen's tooth, that was used. At that time, computers were not very advanced. The sizes of the chips that were used, CCD, were small, so one had to have a minifier. And he was still using a piece of scintillator, of basically a cutout from panoramic screen in order to produce the image from X-rays. He was French, and of course, pointillism started in France at about the same time that the X-ray was being discovered. And the images were put together with the various pixels in an array. Now, this array is not big enough for a panoramic radiograph. And the computer power for making a panoramic radiograph was not yet there. I know Dr. Arai, who's in the audience, back in 1992, 1993, 1994, was doing digital radiography with panoramics. He was right ahead of the game. He and Francis Moyen, they were both experimenting with cone beam CT before the first dental maxillofacial patent was produced in 1995 by Italians. And so we have a look here at the basis of it all, the individual pixel of information. If we take several of these and we put them in a row, guess what? We can make them stand behind a secondary slit, or the equivalent of a secondary slit, and create an image virtually that becomes a panoramic image. It's amazing what happened after Francis Moyen, and not because of Francis Moyen. I mean, he was visionary enough and managed to get the first patent for intraoral imaging, and was the first commercial, or rather the first person to commercialize such a patent. But it only took another 4 or 5 years for the first digital panoramics to come out in the middle of the 1990s. And that's really when panoramic radiology took off, more so than at any other time. So yes, we could digitize images, film images. That wasn't very popular. It didn't really take off in any big way. And nobody invented a film processor that would actually have a linear array to digitize the images as they came out. For some reason, that step was never commercialized. And then another material came out, again in Japan, using actually Kodak patents that were bought by Fuji Corporation. And they made Fuji plates for medicine. And in fact, many dental schools in the 1980s in Japan were already experimenting with these plates for panoramic radiology. So I would say that digital panoramics, in a sense, started 10 years earlier than solid-state digital panoramics, if we think about the early work in Japan. One of the techniques that became available for dentistry was the denoptics, in which one would just take a cassette like that used for film, remove the scintillators, and place in a storage phosphor plate. This was then just used in any machine that would normally take film. Exposed. And then after it was exposed, it could be processed using a solid-state laser. So we have the unrecorded plate with the storage phosphor. We have the stored image, a laser scanner producing blue light from a solid-state red laser. And then afterwards, after the image had been photomultiplied and brought into a computer, one had the erasing of the plate to do. Could use any panoramic machine that was analog immediately by using this technology. But it had no real big advantages over film because it still took several minutes to process the image and to look at the image. You didn't get an instant image. Technology was not terribly expensive, apart from the phosphor plates costing 600 to 1,000, not reals, but American dollars. There are other problems as well. Yes, already, Warren. This is film, there is film in the camera, and storage phosphorated images are susceptible to degradation from excess ambient lighting. So there are issues to consider as far as that is concerned. So let's go back to 1896. People had 3D imaging in 1896. It's called a fluoroscope. Yeah, if you didn't mind your hair falling out and your hands getting cancer, then you could use these devices perfectly well for long exposures. But if you replace the individual's eyes with a camera, you've basically got the Galileos from Sirona. If you move around the patient, you've got basically an image intensifier with a little camera. The oldest technology in the world, apart from the fact that the man's not there. So there are a variety of solid-state detectors. First of all, you have the image intensifier and just regular fluoroscopy. It's an old technology, and quite honestly, the quality of the images is very poor, in my opinion, once you take it away from the proprietary images or proprietary software and take it into DICOM and have to try to read it in native DICOM. Then you have scintillators such as gadolinium oxysulfide, cesium iodide, and sodium iodide. Scintillators plus semiconductor detector use light-absorbing photodiodes. And then we have direct semiconductor detectors such as cadmium telluride and cadmium zinc telluride. These use semiconductor diodes. The difference is that with these techniques we're looking at here, light is produced from X-rays. And light diffuses often and scatters out, so it doesn't produce necessarily a perfectly sharp image. There is a line spread function that can affect more than one pixel and create noise. The direct semiconductor detectors, on the other hand, produce electrons directly from the impact from X-rays. And therefore, as these are channeled to each individual pixel, the image can be much sharper. This is the original way of using photodiode technology, or indirect, sometimes misnamed direct digital radiography. One uses a scintillator such as gadolinium oxysulfide or cesium iodide to produce visible light photons, often then use a fiber optic to channel those lights as accurately as possible, but there's still some scatter. The visible light photons are then detected by a CCD, a CMOS, or some sort of thin film transistor. And this is indirect solid-state technology, often incorrectly labeled as direct digital sensors. As an editor in the past, I have been very quick not to accept the term direct digital imaging from anybody that submitted papers with that terminology when they've used indirect methods with a scintillator. So early on with panoramic radiology, one had retrofits, which were CCDs, which did use this indirect scintillator-based technology. And here's an example of the one of the first digital panoramics that was commercialized, the trophy system that was used with an instrumentarium machine. These retrofits were a problem, however, because whenever one used a retrofit, because you didn't know whether the manufacturer of the panoramic machine component or the manufacturer of the digital detector was to blame if anything went wrong. Let's go back one. I'm having sorry, this is just sticking every time I try to use it. So let's have a look at dedicated solid-state technology and at the scintillator that's involved in this. If we consider the energies that are used in dental radiography, usually one is using something in the order of up to about 90 kV. If we look at the comparison here, we'll find that, in fact, the X-ray energy in keV is much lower than the peak energy. And if we look at the different types of scintillators that are around, silicon, selenium, etc., cadmium, cesium iodide, and then cadmium telluride. Cadmium telluride has a broader spectrum of energy in which it can actually match the energy produced by the source of radiation. We've done studies in the past in my school. My wife and I did work in which we looked at lutetium, and we found that, in fact, often the scintillators that were being used were not well matched with the energy produced by the X-ray tube. In fact, cadmium telluride is even better than the lutetium ceramics that we were trying to use at one time. So here we can see a comparison of cadmium telluride versus amorphous silicon, and again the range of interactions that's possible is much greater with cadmium telluride than with amorphous silicon. If we look at modulation transfer function, if we look at the maximum theoretical modulation transfer function, MTF represents the sharpness of the image taken by digital X-ray sensors. The higher the MTF, the better the image. Sensors make a difference. The maximum theoretical MTF is almost matched with cadmium telluride, CMOS sensors, whereas that is not the case for indirect detectors. If we look at an indirect conversion, we have a spread of visible light that's possible from the scintillator, whereas when electrons are created directly by X-ray interaction, there can be a much sharper image produced. This just gives an example of this, of indirect conversion, the X-rays, versus direct conversion, the X-rays affecting the scintillator, in this case, the cadmium telluride, in this case, and the electrons are very closely or tightly focused at the individual pixels using a semiconductor diode electrical circuit, as opposed to a photodiode. Therefore, with indirect conversion, there's a greater potential for blurred images, and we saw some of those blurred images in the beautiful slide shown by Hugo Dargham, comparing different detectors in the previous lecture. So what's the difference? Raw image, here we have an intraoral sensor and a sharpening tool. When we're dealing with an indirect technique, when we sharpen the image, we're actually losing resolution. That is not the case when we're dealing with cadmium telluride, because we get a sharp image to begin with. We don't need to correct it, so we can maintain the resolution rather than losing it. So with cadmium telluride crystals and CMOS, the DQE can be greater than 90% at 90 kV, the range that is commonly used in panoramic and cone beam CT. The MTF is more than 75% at 2 line pairs per millimeter and more than 40% at 5 line pairs per millimeter. There's a 3 times better DQE, which basically means that there's a 3 times better image quality for diagnostic purposes. Also, the technique can be 3 times more dose efficient, and therefore it can reduce the radiation dose that is necessary to be used. Looking at spatial frequency in terms of modulation, transfer function, the theoretical and the real are very close together. In contrast, resolution is equal with cadmium telluride to that that's found with the other detectors. So let's have a look at an indirect conversion scintillator CCD example. These are examples from 2007 when I first used cadmium telluride. And this was the initial experience I had with the sensor from IAT. And I have 2 of those original sensors back in Louisville, Kentucky, and we're not going to discard them because they're still working perfectly well. And here we can see the quality, the initial crispness of the image that one gets without any need to use edge enhancement with lost resolution. Okay, let's have a look at the manufacture of cadmium telluride CMOS sensors. These are made at the Acrorad in foundry in Okinawa. This is cadmium telluride crystal growth. And these are the cadmium telluride ingots that are produced. These are then sliced into wafers. And the wafers are then treated by photolithography to produce the pixels that are present. These are then diced into detectors. And each of these are about 100 micron pixelated cadmium telluride detector. This is the clean room at IAT, basically at Otaniemi in Finland. It's more spotless than the average operating theater. And this is Konstantinos Spariopoulos, who put together the idea of these sensors in the first place, that is providing to Dabi Atlante. Here we can see the great care with the cadmium telluride wafers. And the quality control that's used. So one gets the CMOS designed to bumped readout circuits. This shows the CMOS layout design, similar to the pictures I showed earlier from the device of Francis Moyen. This is the CMOS wafer. It's then bumped. These are the connections that are going to happen between the cesium iodide and the CMOS for the flow of electrons. The dicing shapes the sensor, and then one has a bumped readout circuit. And this is the scanning electron microscope of the surface of the next generation nanotechnology detector. So with direct conversion, CMOS readout, and bump bonding, one gets close to 100% fill factor, closer than with any other device. There's a better signal readout with no dead time. There's essentially limitless dynamic range and low noise. Here we can see the patented cadmium telluride crystal sensors with the X-ray energy affecting the cadmium telluride, and then the bumped surface. Having great problems with this remote, it's not moving very well. And then readout of the CMOS. Here's an example of one of these diced sensors. Take the readout circuit and the cadmium telluride detector. Then place together very carefully. Here we can see the cadmium telluride and the connection to the CMOS. With direct conversion, is enabled by cadmium telluride or cadmium zinc telluride crystals being directly bonded with a patented process to the CMOS. This layer is able to directly convert radiation to electrical signal. This compares with an older generation scintillator sensor. One has a reflected surface, one gets a use of a scintillator, and the light can spread. In case of older devices where X-ray radiation is converted to light, elements are dispersed in all directions, and that significantly decreases resulting diagnostic value of an image and dose efficiency in some cases. So here's an example of the circuitry from the latest Dabi Atlante panoramic. We have several of these in a row. You think so? I'm not sure. let me stand on the edge here and see if it works better. Okay. Here we have the detectors. I think the batteries are just flat in this, that's all. And this shows that the next generation high-speed microelectronics, this is 100 microns, and 1 pixel now contains more than 2,000 transistors. Here we can see laminographic imaging. We actually don't have, we have a whole zone of up to 3 centimeters, which is totally in focus, that can be selected from to develop the final panoramic radiograph. This provides a unique opportunity among panoramic systems to adjust the focal layer to the ideal for individual patients. And I apologize, we don't have the ability to use the computer on the stage here. Otherwise, I'd be able to show you this happening in firsthand. So you'll have to go to the Dabi Atlante booth to see that happen. So we can have, in the past we had 1 layer that was actually in focus. Now we have multiple layers, up to 3 centimeters thick, that can potentially be selected from and be perfectly in focus. This advantage of frame readout with multi-slice projections means that one can have autofocus and one can have manual focus to select out the image layer that one wants, and there is some limited 3D potential. So one can actually correct the image after the fact and improve orthogonality to have less overlap, even have separate images for the maxilla and mandible if there's a big discrepancy in the size of the jaws. So there's multifocal layer imaging. One can have focus selection. There's a possibility of 2-dimensional rotations, and we can add advanced diagnostic tools. This may be one view, but it can be improved. Here's an example of the first device that I had in the University of Louisville, where we had a particular retrofit to a very basic panoramic corporation machine. And this retrofit was known as a ProFit. But it was covered to begin with in lots and lots and lots of wires, and then simplified into something that, although not beautiful, worked perfectly well. Let's have a look at some examples of images. These are the early images with the technique. Of course, women are more complicated than men, but men would like to just be able to have one spot to press on. And to begin with, I had to actually work out the focus and decide exactly manually where I wanted the panoramic layer to be. Now we have autofocus and can automatically produce a very pretty image with only needing to adjust the image in a minority of cases. This is an example of the Eagle 2D from Dabi Atlante, which uses the cadmium telluride technology. And here are some of the examples of the images that have been taken in clinical practice in Brazil. Here's one which has multiple supernumerary teeth. I think you can see very clearly that the periodontal ligament space is well represented in these cases to a point where there is little or no need to take periapical radiographs. Another example with impacted canines. Case where I would prefer to have cone beam CT, but initially one would start with the panoramic. Yet another example, impacted molars, third molars. This side, we're above the mandibular canal. I would not want to have a cone beam CT. On the other side, because the canal is superimposed on the roots of the teeth, I would certainly think about getting three-dimensional imaging. Bimaxillary projection, sometimes misknown as a bite wing. Bite wings don't show the roots of teeth. One can produce, with reduced dose, images just of the posterior teeth by only exposing those areas. Another example of a bimaxillary view. This is a TMJ series with closed and open. I would never use panoramics for TMJ imaging, but usually, but you can see gross morphological changes and the ability of the condyle to move over the articular eminence. This is a so-called sinus evaluation. Again, I would not restrict myself to using panoramics for sinus views. I would use three-dimensional imaging, cone beam CT, or a full-thickness film. Again, more examples. This is a reduced dose image, minimizing the dose and still getting a reasonable readout. And this is a pedo panoramic using pedo exposure parameters. Cephs as well can be generated using scanning techniques with cadmium telluride. And so can hand-wrist radiographs using the same Ceph attachment. So let's review the next generation direct conversion sensors. They have a DQE, which is particularly high, a very good MTF. They permit laminographic or tomosynthesis image processing. One can have multifocal layer imaging, and generally speaking, one is using IAT sensors, which are patented. So cadmium telluride crystal direct conversion used by Dabi Atlante provides 3 times better image quality as objectively measured by DQE or modulation transfer function. This same technology is now being used in dental. It's also being used in medical for mammography. It's also being used in industrial for looking at the quality control of pharmaceuticals and looking for industrial quality control of equipment. So medical and pharma uses of this same technology are quite widespread now. It's also being used not only for medical and pharma, but also in some cases for security at airports. Obviously, if you can inspect individual capsules for their quality, one can get enough information for diagnosis on a patient. Let's just move forwards briefly to the issue of cone beam CT. With cone beam CT, the PC becomes the procedure control. One has a source of X-ray, which is cone beam. In fact, it's the same as the source of X-rays that were used by everybody from the beginning of dental radiography to take two-dimensional images. You have a divergent beam, therefore it's considered, if it's conical in shape, to be cone beam. In most cases, in many cases, it's pyramidal in shape. One produces a variety of basis images, two-dimensional images, with a minimum of 180-degree rotation around the patient. These raw basis images are then processed in the same PC to produce images that are approximate in quality to an anatomical dissection. In some cases, better than an anatomical dissection. So cone beam CT has some definite advantages over two-dimensional imaging. If we look at this particular view here, we can see that this periapical radiograph has a lot of anatomical noise, such as the patient's nose, soft tissue, the anterior nasal spine, and so forth. Bender and Seltzer, as early as the 1960s, stated that if you didn't have loss of cortical bone, you couldn't see a periapical lesion. If one then takes a transaxial view instead, such as that through this tooth, we can see early changes or healing that is going on within the space above the tooth without there being any disruption of the cortical plate. Anatomical landmarks such as the zygomatic process of the maxilla that can obscure details of the roots of the teeth are taken out of the focus, and one only finds just one pixel dimension, and one can see the lesion that is not so readily apparent on the periapical of the same patient. In fact, cone beam CT shows 34% more periapical lesions than can intraoral radiology. As far as fractures are concerned, Dr. Hugo Diagam showed you a lot of fractures. Not many of them that he showed you, though, could not be seen unless one had cone beam CT. If one has a vertical fracture, which is parallel with the buccolingual direction of the arch, then traditional panoramic and traditional periapicals won't show that lesion, where cone beam CT will. Here we can see a view of the panorama selected out, and one cannot see that lesion on the panoramic view. One can see it on cone beam CT as well by having axial slices where one can actually view different positions within the tooth. However, with cone beam CT, we have to be careful because if there are restorations present, they may cause beam hardening artifact that can be misinterpreted as a root fracture. So, what are the concerns that we have about being green or not being green? First of all, NCRP 160 in 2006 showed that whereas in the early 1980s, background radiation represented 83% of the total dose to the average American, and medical represented 15%, by 2006, background radiation represented 50% and medical represented 48%, more than a threefold increase in radiation exposure to patients, mainly from CT, medical CT, and nuclear medicine. Cone beam CT is very low dose. Panoramic radiology is very low dose. However, our aim should be to minimize the dose to as low as achievable, and that is possible using high quality, highly sensitive detectors. There have been problems in the United States with the New York Times asking about or describing radiation worries for children in dentist chairs based upon the excessive use of cone beam CT from not having adequate selection criteria and not having adequate technology in the past. In fact, when this was written, there were machines that were being designed and produced by Hitachi in Japan and by Illuma in the United States that actually produced doses that were equivalent to or even exceeded medical multi-detector CT imaging in terms of dose. As we saw from Dr. Dargam's presentation, that circumstance is perhaps being reduced. We're down now to maybe a quarter of what was being done just 3 or 4 years ago. So we have seen manufacturers definitely making improvements and moving towards better scintillators or where scintillators are used, or better detectors where scintillators are not being used, is definitely one of the ways that we can do this. In the United States and worldwide, actually, in medicine, there's the Image Wisely activity to try to select the images appropriately, and the Image Gently campaign to reduce dose to children, because children and teenagers can be up to 10 times more sensitive to radiation than older adults, and 3 to 5 times more sensitive than younger adults. So if we're thinking about radiation safety, we have to be particularly concerned about radiation dose to children. Much of this is not the manufacturers, but we, the dentists' choice in making appropriate selection criteria. We certainly shouldn't be buying machines that don't have a specific pediatric option. Now, bottom line, the question that the few of you that have remained in the audience while I've been playing with this and not doing very well and not showing you any interesting cases directly from my computer. Okay, traditional flat panels have been used to date for maxillofacial cone beam CT, and they still are. Dabi Atlante Eagle 3D uses a scintillator at this point in time. They are fairly close to having a cadmium telluride small field of view cone beam CT detector. And Konstantinos in IAT says that X-Counter AB, the mother company of IAT, has developed a CMOS CdTe sensor, which is 7.5 by 5 centimeters, using dual threshold energy bins and photon counting with a pixel dimension of 100 microns and a frame rate of around 300 frames per second. So it's there, almost. not quite, but almost there, that we will be able to take this technology, which has significantly improved panoramic and cephalometric radiography with high-quality images at low dose, and bring them into the field of cone beam CT. So that's the end of my presentation. Again, I apologize for having great difficulties with this device. I really do think it needs new batteries. Maybe I need new batteries in my head. I also apologize again for speaking in English rather than in Portuguese, or in a language that is closer to Portuguese. And those of you who are here having to listen to the translators who had not got a transcript in advance and therefore have been doing this on the fly. Thank you for the translation you've been doing. Questions? Everybody's absolutely exhausted, and I believe that in this part of the world you start in the middle of the day because everybody parties all night on the beach and to avoid the suntans and the radiation. Because, you know, Brazil unfortunately has another reputation, and that is that it does, where we are now, does have a much higher background radiation dose than just about anywhere else in the world, with the exception of Kerala in India. So if you think you're getting a suntan, it may be something else that's giving you the tan. It's about something like 3 times as much radiation as you get in Denver. In the United States, which is about as high as it gets in the United States. And nobody here has been said to have cancer because of that, or it hasn't been detected. And there's probably no great difference between radiation from those sources on the beach. So the radiation on the beach is pretty good, especially when you're looking at the other gender. They have very nice bodies here. Can I compliment you any more? I didn't say male or female.
What's your thoughts about your new regulation in the United States and the European Academy?
There aren't any. Yeah, there aren't any regulations from European or American Academy. There are guidelines from these. There are regulations in some parts of Europe at the moment in terms of the need to document dose, and those regulations may come to the United States. However, the European and the American societies of radiation physics are debating what radiation dose means. There is a fairly big move away from effective dose as meaning very much in terms of recording dose for patients. There's more of an idea that we should be looking at the total energy applied to a particular part of the body rather than trying to equate that with potentials for damage to different parts of the body.
Because as you see in the news or in the media, there is a lot of concern about what the orthodontic people or even the implantology people is applying to their patients. And now with endo, like we saw just minutes before your presentation, that mostly a lot of endodontics people are prescribing CTs in all cases, no matter if they have doubt or not. What are your thoughts about that?
Well, there are certain things that one should always remember, and that is that there are, in America they call it apple pie and motherhood. There are certain baseline features that one should always remember, and that is that nothing should ever be routine when it comes to the use of X-rays. So every patient should be examined by the clinician, not by his dental assistant. I had a call from a CNN journalist, and she said, "What do you think about this? I just phoned for an appointment for my daughter, and the dental assistant that answered the phone told me to bring my daughter in to have a full mouth series of radiographs. Does she need them? She had some taken a year ago." I said, "Well, I don't know. I don't think the assistant knows. The dentist should be checking that patient clinically to determine whether or not they need to have the radiographs taken by looking in the mouth and asking questions. And it should be directed to the individual patient. And if we need to take a radiograph, then we need to take it with enough radiation to make a diagnostic image and try to use a system that's got as sensitive a detector as possible so we can minimize dose. So we first of all decide what radiographs need to be taken, then we try to minimize the dose, but not to a point below that which is diagnostic. I have students that want to have cone beam CTs for orthodontics sometimes. We don't have every patient cone beam CT, it's rare. But if they have impacted canines, they want to have cone beam CT usually. So many of them think, oh, let's use a whole head cone beam CT at very low resolution. I've told them, I can't tell you whether there's ankylosis. I can't tell you whether the periodontal ligament space is intact around those impacted canines. You're going to have to take a higher resolution local area view for that particular purpose, and then decide whether there's surgery or asymmetry that warrants having three-dimensional imaging for the rest of the considerations. My biggest concern with orthodontics, I've got two concerns with orthodontics. The first concern is that there are two very, very, very rich companies that give money to the American Association of Orthodontists and probably equivalent organizations all over the world. These are Invisalign, and there is a Sure Smile, in which they pretty much recommend taking cone beam CTs at multiple times as more or less a replacement for impression material or visible light, where radiation is not necessary on these younger individuals. They're very potent, they're very powerful. The American Academy of Oral Maxillofacial Radiology came up with some excellent guidelines for use of cone beam CT. The orthodontists were part of that to begin with, and their orthodontists that they selected remained as authors of that document. But I think, I can't prove it, but I would suggest that there may have been certain pressures that had the AAO deciding that they didn't wish to have their names associated with guidelines that would restrict the use of radiation on orthodontic patients. Do we know whether there is an ill effect on patients from radiation? No. We can't point to an individual and say there's a definite effect. But Eric Hall gave the first Julian Gibbs presentation at the American Academy meeting in Beverly Hills just a few weeks ago. He said, you know, most people think that the radiation doses that were received in Hiroshima and Nagasaki all those years ago were very, very high doses. Yeah, the very high doses, they also got bomb blasts and they got heat waves and they died. The ones that survived and the ones that were miles and miles away from the epicenter actually got diagnostic levels of radiation dose. And so we do have cohorts over many, many years of individuals that had diagnostic radiation doses and did have ill effects, and a very small percentage of cases. So the point is, what are the chances? It may be 1%, it may be 5%. And it may vary dependent upon the individuals. When the international meeting of dentomaxillofacial radiology was in Hiroshima, they had some excellent presentations that showed that some individuals were susceptible to get leukemia, but it was only 5% of the population, based upon their human genome, that were susceptible to leukemia. And there were 5 types of leukemia, and they all represented a possibility of 1% of the particular population getting leukemia at all. So there are things that we're going to see in the future. We always talk about evidence-based dentistry nowadays, and evidence-based medicine, Cochrane Foundation. I've written for the Cochrane Library. I've done those types of study. But they take into account population averages, good statistical models. But we are not the average, and therefore the statistical model doesn't apply to the individual always. And so we, in the future, will find that a lot of what we consider to be really good evidence today is very poor evidence tomorrow. Maybe that's not the case for dental materials. But when it comes to something like biological effects of ionizing radiation, we have a long way to go before we fully understand the relevance and the importance and which particular individuals are most susceptible. So at the moment, we act probably more carefully than we possibly need to be, but it's probably better to be safe than sorry.
I agree. I agree 100% in your thoughts. And my other point is, how about the concept of stochastic effect? What's your thoughts about?
I believe in stochastic effects. I believe that if I buy enough lottery tickets in the Kentucky lottery, I have a better chance of winning. But I also believe that if I buy one lottery ticket, I've still got a chance of winning. Less so. Same with radiation. If I happen to get a small amount of radiation, I can be unlucky, as opposed to lucky with the lottery. If I have more radiation, I'm more likely to be unlucky.
I agree. Thank you very much.
Well, I know Dr. Arai in the audience here, and I apologize to him for boring him. He knows all about this stuff already. But I would certainly recommend all of you to go and see Dr. Arai's presentation. He is definitely one of the pioneers of three-dimensional imaging for dentistry. Cone beam CT is not a dental invention. It started theoretically before the middle of the 1970s, with the NIH giving a grant to the Mayo Clinic and the development of a system over 3 years with a production in 1978, before the Feldkamp back projection algorithms were available. It became a product for medicine in 1983, with Siemens developing C-arms for inspection in angiology and angiography. And then cone beam CT today is used for a whole host of different technologies or systems. It's used in radiation therapy, for planning radiation therapy. It's used in, often associated with the linear accelerators or the newer mobile units. It's used for mammography. It's used for cardiology. It's used for ear, nose, and throat, the same machines that we use. So it's very difficult for some people to say it's different. It is a form of CT, and it started about the same time that multi-slice CT started, but was hampered by the need for better computing power than was available at the time when it was being developed. We also must bear in mind that the future of cone beam CT may well rest with people like Dr. Arai and the other people in the audience here, because dentistry is no different than medicine, and what we do in dentistry may become valuable to medicine. And that's the dentists who are here, but also the engineers working for companies. Think about the work that Roberto Maltini has been doing with the IEC in terms of evaluation and considerations of Hounsfield units and their imprecision, not only with cone beam CT, but with variations of voltage with multi-detector CT. And as we move from 1 to 2 to 4 to 8 to 16 to 64 to now 312 slices at one time, the geometry for multi-detector CT becomes in some ways very similar to that for cone beam CT. And many of the issues that we have become very similar. We also have to remember that there's a tendency for manufacturers to say, oh, very low dose. It's only dental CT. It's only cone beam CT. Very low dose. The reality is that they then look at the radiation dose for multi-detector CTs that were being used in the early 1990s. The dose has come down by a factor of an order of magnitude in medical CT since that time. And if we're going to compare adequately, then we should be comparing with modern multi-detector CT, both for image quality, which is much better than it used to be, and for radiation dose. And if we are looking at the whole gamut, the whole range, we should be using multi-detector CT if we need to have soft tissue contrast for the maxillofacial area. Although cone beam CT can show soft tissue details, otherwise it wouldn't be used for mammography. So we have a lot to think about, and a lot of misconceptions to think about. And you know, certainly now we think, oh, everything has to be 3D. Not everything can be 3D. Cone beam CT artifact doesn't exist if you have 4 teeth in a row and you put them in a cone beam CT machine. You don't have problems with superimposition of the other arch or the opposite side of the arch. You don't have problems with restorations. You don't have problems with all of those types of artifacts if you've just got a line of extracted teeth in plaster mounds. And unfortunately, studies which are totally unrelated to anything clinical or reality in a patient are published in our journals. And it's a pity, because it leads to misconceptions like, oh, we can use cone beam CT to look for dental caries, which is a very, very bad idea unless you want to restore every tooth in a lot of patients' mouths and you want to find more caries to enhance the wealth of the dental practitioners at the expense of their patients. Well, thank you for being here. I'm going to be around for the next day or two. I'll bring my computer down to the Dabi booth because I really would prefer to show you some of these images and change the three-dimensionality of them, which I can't do because we don't have a VHF connection here, which I had expected there might be. That's why I carried 3 computers with me in my backpack. I've used none of them. And I'd like to thank the Dabi people here. They paid my way here to this meeting. They're supporting the meeting by bringing me to give you an English lesson.
Hello. Obrigado. Mr. Farman, we really appreciate your lecture. Thank you very much. And we have some gift and your certificate here. Thank you.